All right.
Yes, I can hear you.
Oh, sweet. So my name is Emma. I'm a fourth year medical student, gearing up for match fairly soon. And today we are going to talk about chest pain. I think that you guys have talked about chest pain in one context or another. If you've been a sort of frequent flyer for virtual rounds, or you've probably heard about chest pain in one context or another. So it's a pretty kind of high yield topic to medicine in general. And a lot of times, no matter what you're in, you'll often be faced with chest pain. So we're going to talk about, and it's not just going to be cardiac chest pain that we're going to talk about. We're going to talk about the breadth of kind of chest pain and how we approach it. Okay. Cool. So let me give you this pre-poll. If you have been to a session with me before, you know that I like to give you these pre-polls just to kind of gauge where you're at right now. So here's the pre-poll. Just be honest, kind of click in your vote in terms of where you're at right now with your knowledge about chest pain. Ooh, one person knows a lot. All right, we'll stop it there. Oh, one person got in. If there's anybody else, speak now. All right, we'll end it there. Okay, so it looks like the vast majority of you guys said that you know a little. Some of you guys said that you know nothing, which is totally okay. When I was in your shoes, I probably didn't know anything about chest pain either, except for maybe like elevated troponins or, you know, whatever. But some of you said you know some, which is great. And then one person said they know a lot, which is even better. I should find that person and make them present this. But good, no matter where you're at, hopefully you can learn something here tonight. And we'll have a little bit of fun with it too. It won't be all kind of serious business. Move in here, and we'll go through the format and everything here in a second in case you're panicking and don't know the format of virtual rounds or what to do or all those things. We'll go through that, so no fear. And here it is. So what we're going to do today, and because chest pain is such a broad topic, I decided to do what I've been doing in a few sessions, which is focusing on multiple cases. This time I chose two so that we can kind of go in a little more depth than rapid cases. And then we're going to go through the slide at the end that's kind of rapid fire imaging and to diagnose other causes of chest pain. So what do you guys do? I would love if you guys actively participated. You can talk, unmute yourself if you want. Feel free to interrupt me, that's totally okay. And I'm going to ask two of you at least to read some cases. I have two cases. They're very, very short, so don't be afraid. And then I put it in the chat, but what your guys' role is to get kind of a certificate of completion for this is to fill out that SOAP note. So if you go on the document, click on the chest pain for today's date. Today is the 23rd. It's approach to chest pain. If you click on that, it'll take you to the link for the quiz. That has both the SOAP note that you'll fill out for one case, as well as the quiz, which I made, and I can attest to the fact that it's easy. So it should take you 1 or 2 times to complete it. If it takes you 3, it doesn't necessarily mean anything. It's a fairly simple quiz, and I make them easy for you guys because I know you're studying a lot of stuff and you're busy and stressed and all of those things. So I make it fairly easy for you guys so you can knock it out right after this, if you pay even a little bit of attention. Okay. And you may be wondering in your head who this animal is over. Oh, didn't mean to do that. Who this animal is over here to the right. That's our foster dog right now. He's absolutely crazy. We promised we would never foster again because we're foster failures. But here we are fostering again. Hopefully we don't fail again. But yeah, he is very, very cute, but he's very bad. He's a very bad puppy, but all puppies are bad until they get not bad, until they grow up. Let's keep going. Okay, so here's the SOAP note form. And you're wondering like, what's SOAP? I've never heard of that. That's okay. What it is it's an acronym. Okay, so it stands for subjective, objective, assessment, and plan. So when we talk about subjective things, we're talking about the things that the patient tells us. So kind of the history of present illness, what's bringing them to the ED or to the hospital or to the clinic or whatever. And then review of systems, which is pertinent. So in today's lesson, if we're talking about chest pain, we're going to want to talk about or ask about if they had shortness of breath, or if they had palpitations, feeling like their heart is racing, if they've had a cough, fever, if they've had leg swelling, nausea, vomiting, sweating, things like that, or dizziness, lightheadedness, things that are pertinent positives or negatives to what's going on in the kind of history right now. Objective, those things are vital signs and physical exam findings. So those are things that we kind of find. And then the last part is assessment and plan. So we're going to kind of put our assessment in terms of what we think is going on, and then plan to address that. So, if we think the chest pain etiology is an aortic dissection, what the plan will be, what we're going to do in order to rectify that pathology. Okay, so in some of my cases, they're not super extensive where all this stuff is going to be laid out where you can like copy and paste, if you will. So for some of this, fill it out to the best of your ability. If we don't put a whole assessment and plan, that's okay. I'm going to go through the pathology where we're going to talk about the actual pathology and kind of break down the anatomy, physiology, things along those lines to kind of talk about, what the treatment would be, or, what the risk factors and stuff like that are. So kind of hone in on that information and then kind of plug it into your SOAP as best as you can. Okay. All right, so let's start with a little bit of a lesson about sort of the etiology of chest pain. As you can probably imagine, it can be, pretty multifaceted. It can be in different organ systems that cause the chest pain. Okay. According to the text that I was reading, currently in my emergency medicine rotation, so you talking about chest pain is kind of hits right at home right now in the rotation I'm in. But in the text that I was reading, it listed these 8 things as the most common causes of chest pain. Okay, so I put them on my slide. I think that they are also, fairly common. And when we talk about these things, these are usually the things that are pretty serious and life-threatening causes of chest pain. Okay, so if we look over here to the right, number 1 is acute coronary syndrome. So when we talk about acute coronary syndrome, that's 3 things. That's ST segment elevation, myocardial infarction. That's a Stemi. That's we'll talk about this in a minute when you kind of see the ST segment of the EKG elevated because of a blockage in the artery. And then the other one is, this should have an I here, but this is a non-STEMI, which is still a heart attack, and you have leakage of troponins, the cardiac enzymes, but you don't see that that elevation in that ST segment. I'll show you exactly what that looks like if you are a little bit confused right now. The other one is unstable angina, so that's like a essentially, and that's sort of a worsening chest pain that's sort of happening at rest and sort of progressively worsening. What are other causes of chest pain? We can talk about an aortic dissection where we get kind of a false lumen in the wall of the actual aorta, which is a problem because that can rupture and cause problems. Usually people with hypertension have that issue. And then other things, we can talk about infections like pericarditis, so infection of the pericardium of the heart. Or myocarditis, similarly, infection of the myocardium of the heart. And so obviously these ones are cardiac causes of chest pain. And then the other things that we can talk about are lung causes of chest pain, because as you know, not all that is chest pain is cardiac. So we can talk about things like a pneumothorax or a dropped lung. So sometimes if there's a stab wound or some sort of trauma. We can get a tension pneumothorax where the mediastinum sort of shifts to one side as a result of air coming in where it's not supposed to be. So the lung drops, air comes in, it pushes the lung over. That's an emergency because that can lead to decreased cardiac output and sort of shock as a result. Other things that we're going to talk about that are pretty life-threatening, and we always want to have on our differential for pulmonary embolism, especially in the ED, or for chest pain rather, is pulmonary embolism. Okay, and so that's a clot in the pulmonary artery, can be very, very serious. Other things are esophageal rupture, so things like Boerhaave syndrome, so sort of active retching, vomiting can cause a longitudinal tear in the esophagus, and kind of you can leak air into the mediastinum. Our physical exam finding there is when we push on the chest wall, we can hear subcutaneous air or subcutaneous emphysema. We call that Hammond's crunch. It kind of sounds like Rice Krispies. It's one of those things that you know, when you actually see it, it definitely does sound like that, like Rice Krispies under the skin. And then the other one is a perforated peptic ulcer. So we can see, you know, as a result of H. pylori infection or NSAID use, we can see an ulcer in the duodenum or the stomach that goes through the wall of either the duodenum or stomach and causes a leakage of air. And what we'll see there is air under the diaphragm. And then finally, the last one is pneumonia. Okay, that's probably one that kind of came to your guys' mind. So, but here's a little introduction to chest pain so far. Let's keep going here. We'll keep talking about some other things. So the other thing that I want to kind of introduce here is the difference between stable angina, unstable angina, Stemi, and Stemi. Okay, so when we talk about stable angina, the thing that we're kind of looking at here is chest pain that happens when there is an increased demand. So what we're seeing is, like, you know, the hypertensive patient with high cholesterol is walking his dog up the hill and then gets a little bit of chest pain, but when he stops, it goes away. Okay, and what we're seeing there is artery, and because we have this plaque, this atherosclerosis in the heart arteries, when we get an increased demand of blood, it can't kind of fit the blood flow can't meet the demand, and so we get that pain as a result. But what we see is there's no infarct, and the EKG looks okay. We might see something on a stress test, maybe we might see ST depressions, but that's another story for another day. Unstable angina, what that is we might see that same plaque, that atherosclerosis, kind of rupture, and as a result we can get partial occlusion of that vessel, and we usually see this at rest, or it's sort of rapidly progressing, so these people are getting pretty sick over time, and we see this as a supply ischemia. There's no infarct just yet, but we'll see things like ST depressions because of that ischemia, or inverted T waves, which we see right here. Okay, and we're going to go through an EKG here in a few minutes. And then the other thing is Stemi. So with both Stemi and Stemi, what we're seeing is, because of the ischemia, the damage to the heart, we see increase in troponins. So we see that leakage from the heart. So we can't use troponins to differentiate between the two. So what do we use? We use the EKG. So with the Stemi, as the name kind of suggests, the ST segment is elevated. Okay. And we can kind of see that over here in the right image. It's kind of a gross exaggeration there in the cartoon. It's pretty tall there, that ST segment elevation. So let me draw it out so you guys can see the actual parts of the EKG. So we see the P wave over here. I should probably draw it on the other one, but P, that's for atrial depolarization. So the atria are depolarizing, getting that electrical signal. Then we see the downward deflection that is a Q wave. And then the upward deflection is the R wave. And then the S wave is the part kind of coming up. And then the T wave is the part over here. So the QRS, that's the ventricles depolarizing. And then we see the T wave, that is the ventricles repolarizing. Okay. And so what we're seeing is sort of this ST segment is elevated. So usually we kind of see it like this, and then there's a little bit of a Q wave. Here's a R wave. There's the S, and then we see it kind of come up, and then there's a nice little T wave. And then what we're kind of seeing instead, as this image kind of suggests, is we're seeing that ST segment elevation right here. Okay, so that is indicative of a transmural infarct, so through the wall, and that's problematic. We need to get those people to the cath lab, or if we're far away from a cath lab or they have shock, then we want to use thrombolytics. Okay, all right, let's keep going. All right, so we can kind of approach chest pain, just kind of from start to finish, because there's so many etiologies to chest pain. So if we kind of start at the top, the patient, presents with chest pain, we need to kind of delineate if this is coming from the heart or not. So does the pain travel? The mnemonic that I use and a lot of people use is old carts. So onset, location, duration, character, aggravating or alleviating factors. Does it radiate? What's the timing of it, and how severe? So that's what I use in my head to make sure I'm asking all the right things. Is the pain typical or atypical of angina? Does the pain travel to the arm? Does it travel to the jaw? Does it travel through to the back? Those are all important. If it travels through the back, we might be thinking of something more like an aortic dissection. But if we say, yes, this is, something that has to do with, or we think it's more cardiac in nature, then we're going down that route, basically. And then we are going to obviously get an EKG right away. That's a pretty quick thing to do. Is it normal or is it abnormal? If it's abnormal, if it is abnormal, or this is asking if it's normal. So if it's normal, then we'll measure troponins, and usually if it's abnormal, we will as well. But if the troponins are elevated, and the EKG is normal, then that's what we're kind of calling an end Stemi. Okay, and then if it's not normal, if there's ST segment elevations or a new left bundle branch block, then that might be what we call a Stemi. But the other side of the story that we haven't really talked about today is, or talked about yet, is this idea if there is a clinical suspicion of a pulmonary embolism. So somebody of whom is short of breath, has risk factors for a lower extremity blood clot, whether that's immobilization, they have a malignancy, they recently had surgery, they just gave birth, they have more estrogen, they have a pleuritic chest pain, which means it's worsened when they take a deep breath, anything like that, that sort of raises our suspicion for pulmonary embolism. Okay, and we'll want to calculate the Wells score. We're going to talk about that a little bit later, and the Wells score kind of points us in the direction of, is a PE likely or not? Okay, and then we're obviously going to do a physical exam, or physical exam, and kind of see, is there different things like dullness to percussion, because that might be more of a pneumonia. If there is dullness to percussion, then we'll want to get a chest X-ray in that regard. And then this kind of goes down this way, which is like less of chest pain, like costochondritis or anxiety or things like that. And we're going to kind of part a little bit later as well, when we get down that branch of pulmonary embolism. If we think it is a PE, getting things like a D dimer, if it's less likely to kind of rule it out. or getting a CT scan to see if there is in fact a blood clot in the pulmonary artery. Okay, so this is kind of an approach to chest pain, you know, you know, just with the idea that chest pain could be a lot of things. So we can't say chest pain, okay, it's probably a cardiac problem. We have to have lots of things on our differential so that we don't miss these things that are pretty serious. All right, let's keep going. Okay, so we've arrived. We're at our first case. I'm going to ask one very kind person to read the first case, if you will.
Oh, I would like to read it.
Sweet, go ahead.
Okay. A 66-year-old male with a pulmonary PMH, HCN, DM, and HLD presents with a gradual onset of chest pain that started while cooking this afternoon. Starts it, feels crushing, is 10 out of 10 in nature, and is associated with nausea, vomiting, and dysuresis. The patient is a current cigarette smoker. PE reveals tachycardia with an S3 gallop. BP 101/67 and cracks in the lower lobes.
Old cards, okay, and that's onset, location, duration, character, aggravating and alleviating factors, and does it radiate, timing, and severity. So that's more of a mnemonic for basically for history taking. It's not just for chest pain, okay? So what other questions do you guys want to know from this guy, or what tests do you want to order? Do you have enough information to pull the trigger on some tests? Oh, good. So does anything make it better or worse? Sure. Yeah. What's one thing we definitely want to ask in terms of worsening factors? Does this exacerbate your pain? We talked about it a little bit when it comes to one specific etiology. Description of the pain, sure. Chest x-ray and EKG, I agree. Does rest? Yeah, does rest make it better? Is it there all the time? Excellent. Yeah, does breathing make it worse? I agree with you, Madeline. I definitely want to know that. Does the pain kind of worsen when you take a deep breath? Because that might point us in the direction of maybe a pulmonary embolism. Okay, so good. I want an EKG too. I want a chest x-ray too. Anything else? Does the pain go anywhere? Yeah, I want to know if the pain radiates. Excellent. We want troponins, good. CBC, CMP. Yeah, we can go ahead and do that. What are we looking for CBC? Are we just doing it? How long has it been going on? Yeah, exactly. If this guy has chest pain for 12 years, it could be something that's serious, but it's less likely. Yeah, Wbc count, exactly. I want to look at the Wbc count to see if this isn't a cause of infection, such as pericarditis, myocarditis, things like that. Yeah, has he taken any medication for it? We want to see if this guy is taking like maybe nitroglycerin, which dilates, venodilates, and helps relieve the chest pain. Sure. Okay, so you guys want, yeah, examine for edema. I agree. All right, let me clear all this. We'll keep going here.
I have a question about the soap note.
Yeah.
Are we supposed to fill it out like while you're presenting, or do we fill it out after?
It's probably easier if you do fill it out while I am presenting. You certainly can afterwards if that's easier for you and you just want to, watch and pay attention. But it's sometimes easier when the slides are up and we're talking about it. You can type it in pretty quickly. Totally up to you. Either way.
Okay.
All right. So, here's your troponin. This is elevated. We say it's elevated when it's greater than 0.04. Okay, so we know that something is going on here. And we'll want to do serial troponins to see if this is elevating. And we don't really know when this chest pain started so far. Well, we can say it, it started fairly recently. But what else do we have here? Let's keep looking. All right, here's a chest x-ray. Does anybody see anything bad? So my way of looking at this, and that's a kind of rhetorical, hard question, because looking at chest x-rays sometimes is like watching paint dry. It's pretty tough. But, you know, the way I look at chest x-rays is I use the mnemonic A, that was a horrible A, B, C, D, E. So A is for airway. So I kind of look at the airway, look at the trachea, look at the carina, look at the left and right main stem bronchus. B is for bone. So looking at each of the ribs, making sure it's good inspiratory effort. You should see about 7 to 12, 7-ish ribs in the X-ray. C is for cardiac. So we're going to look at the cardiac silhouette. Make sure the aortic knob is super big. If we see a big shadow for the aortic knob, that might be worrisome for an aortic dissection. D is for diaphragm. So we're going to look at both diaphragms. You'll notice that the diaphragm on the right side is a little bit higher because of the liver. That's completely normal. And what's this right here? This is an just to help you a little bit. This is an upright X-ray. Just to give you a little bit of context. So it is part of the it's part of the stomach, and it's a gas bubble. So we'll see that air rises, and this is a normal finding. So we can usually tell what kind of X-ray it is, whether it's an AP or a PA. So for PAs, usually the patient's upright, and because they're upright, we can see that gas bubble. Okay, so and then usually for APs, anterior to posterior, the patient's really sick, so usually it's shot in the bed. They put the little backboard behind and they shoot the X-ray while they're in the bed. So this patient was well enough to go to X-ray and stand up, so we see that gas bubble. But this is a normal chest X-ray, and E is for everything else, by the way. So usually in terms of everything else, I look at the clavicles, make sure they're not rotated one way or the other, and look at the other aspects of the X-ray. But this is a normal chest X-ray. What is the bottom right? More air. Yeah, this is part of the intestines down here, so that's just more air. And then if we look at the stomach, we can see if there's air or stool, if the patient's constipated or whatever else. Okay, so here's your EKG. Somebody tell me what you see, if you see anything. You can guess if you're unsure. Remember, our normal our EKG looks like, here's the P wave for atrial polarization. Here's or it should be a little more room, but here's the Q. Oh, that was a horrible QRS. There's Q, R, and then S, and then we'll see a little up wave and then a T wave. Yeah, good. What leads do we see ST elevation in, my friends? So remember, this one is lead 1, 2, 3. Then we have AVR, AVL, AVF. And then V1, V2, V3, and we'll talk about what this all means here in a second. But yes, we see 3. What else? So definitely 3. I agree with you. We see ST segment elevation. 3. What else? 2. Yes. 2, 3, and 1 more. Definitely. So 2, 3, and then there's 1 more that I'm close. AVF. There's more, the ST segment elevation in AVF. And what does this tell us, guys? Knowing what we know, this guy has an elevated troponin. He has ST segment elevation. What are we calling this? What is his diagnosis? Stemi. Good. I agree with you guys, and I think you guys can diagnose a STEMI, and we'll talk about what that means in the EKG, in terms of what artery this is and how we're going to treat that. Okay, so good job with this one. And what is a STEMI? Basically, a STEMI is when we get kind of that blockage in the coronary artery, and there's different arteries that we're going to talk about here in a second. But what are the risk factors? This guy had a few of them. Age greater than 65, and a lot of these risk factors are included in the TIMI score. So that tells us, what actually is the risk factor here. But what are the other risk factors? They are presence of known coronary artery stenosis. So these are things like if the patient had a coronary artery bypass, they had a prior MI, they've had a stent or had an angioplasty. These increase your risk. The patient is on aspirin, which means they might have some sort of risk factor for clotting. Other than this, they have 2 episodes of chest pain in the last 24 hours. They have ST changes. We definitely had that. They had changes in their cardiac biomarker elevation. We look at troponins. There are other things that are non-specific, like myoglobin or CKMB, but those are far less specific. Other things that we're looking at are risk factors of coronary artery disease. High blood pressure. Our dude definitely had that. Diabetes, he had that as well. And then family history of coronary artery disease or MI. So, and that's premature. So we're looking at a first degree relative or their father or a female first degree relative less than 65. So that's what we're looking at in terms of age. So father less than 55 or mother less than 65. The other things are elevated LDL, that's a cholesterol marker. Or reduced HDL. HDL is the good cholesterol. So if we have a reduced HDL or an elevated LDL, those are both risks. And then smoking in the last 5 years. Our guy smoked as well. So how do we treat this? Initially, we're going to do a few things. We're going to give morphine, oxygen. We're going to give nitrates to dilate the vessels. And we're going to give aspirin. You'll probably see the 81 milligram aspirin being given if you guys are scribes in the ED to chew on as a mechanism to inhibit cyclooxygenase to prevent clotting. The other thing is platelet inhibitors like clopidogrel. We give that as well. We give beta blockers, ACE inhibitors, statin for the cholesterol, and then heparin as well. So the mnemonic for that is Mona C. Bash. Oops. Sorry, team. Mona C. Bash. That's what we put in there to kind of remember. But the definitive therapy for myocardial infarction, whether it's STEMI or non-STEMI, we know that there's something blocking the arteries. So what do? We get the blockage out of there. And how we do that is reperfusion therapy. So we use percutaneous coronary intervention. So they go to the cath lab and we have different standards in terms of getting the patient to the cath lab. So that's why when we see a STEMI, it's very time sensitive. We want to get them to the cath lab to reperfuse them rather rapidly. But when do we use thrombolytics? So things like TPA to bust the clot up. It's pretty uncommon unless the patient is in shock or coronary congestive heart failure because of this MI, or they're far away from a cath lab. So if this guy is having a STEMI in the middle of nowhere and can't get to the cath lab for over 90 minutes, then we might give TPA in that instance. But otherwise, the gold standard treatment is cath lab, percutaneous coronary intervention. Okay, so we have to get him to the cath lab. All right, and then what are the other causes of acute coronary syndrome? That's unstable angina and STEMI. We talked a little bit about that so far, but let's keep going here. Let me clear all this junk out of here and we'll keep going. And we're going to talk about the EKG a little bit here in a second. All right, so let's kind of keep it simple here. We'll start over here in the upper right-hand corner. We're talking about the coronary arteries. So we're talking a little bit about anatomy here. And the three main vessels that we're going to talk about here are a few things. So we're going to talk about the left main coronary artery, that's which branches to the left circumflex. So you'll see sometimes that abbreviated as left circumflex like this. And then the other one is left anterior descending artery. So the main ones that we're looking at here is, yes, the main coronary artery. And usually when that is blocked, that's really bad, because you can get decreased blood flow to both the circumflex and the left anterior descending artery. And then the other one over here is the right coronary artery, and that's over here. The one that's pretty serious that we look at is the left anterior descending. We call that serious because it can cause pretty serious problems when it is infarcted. It's called the widowmaker. But what we're going to see on these actual EKG is the actual lead placement sort of will tell us on the EKG, will tell us which coronary artery is infarcted. Okay, so next I want to kind of point your attention to this image down here in the bottom right hand corner. And what we're seeing here is we're putting different leads on the patient so that we can kind of discern what's going on. Okay, and what we have a lead over on the left arm, that's AVL. So that's what you see over here, okay, AVL. We have one on the right, that's AVR. Okay, and then AVF is down on the leg. I remember F for foot. Okay, and then we will have the precordial leads, V1 through 6 across the chest. Okay, and then the vector of lead 1 kind of goes from the right arm to the left, and then we see lead 2 and 3 have vectors as well. And this is kind of the heart in the middle. Okay, so we know that the vector of electricity of the heart is coming from the right atria and is kind of going down towards the ventricles. So it should always be like this, okay? And when we're talking about that, we know that there should always be an upward deflection in AVL, and it's going away from AVR, so it should be negative in AVR, okay? So I know that that's kind of a lot right now, but basically what we're seeing, a normal waveform is, here's the P wave, and it's drawn out a lot better than I drew out. Mine looked like probably a STEMI. But here's the P wave. And what we say the P wave is we're talking about electricity. The electrocardiogram, no surprise, is electricity of the heart. Okay. And when we look at it, the P deflection is when the atria is depolarizing. So it's getting the electricity and then being sent from the AV node to the SA node to then depolarize the ventricles, which is the QRS complex. Okay, so we're good. So the P wave is kind of here. The QRS is when it's here. And then the ventricles depolarize. Then we get the T wave, which is ventricular repolarization. Okay, so when the ventricles are repolarizing, getting ready for their next electrical signal. All right, so when we look at the EKG, we can kind of bunch it by different basically different blocks of the EKG having abnormalities tells us which coronary artery. Okay, so if we see ST segment elevation in 2, 3, and AVF, because of that lead placement, it tells us that that is in the right coronary artery. Okay, so 2, 3, and AVF, and that's where our guy had an inferior STEMI. So that tells us that's a left, or I'm sorry, the right coronary artery because of that lead placement. And then let me change my color here. And if we have an anterior coronary artery problem, or an anterior on the EKG, that tells us that's a left anterior descending. So if you imagine the leads kind of V1 through V3 or 4 go in that area. So that tells us that's a problem with the left anterior descending over here. And so that's V1 through V4. So if there's a problem there, that tells us that is the left anterior descending. And then there's a lateral, which is AVL and then V5 and V6, because they're kind of over on this lateral side over here. So AVL, V5 and V6. Let me get a new color and we'll kind of dissect it here. So there's V5, V6, and then AVL. That tells us that that's the circumflex artery. So I'm keeping it simple. They break it down, even further into anterior septal and, all these other things. But that, because of where the leads are placed on the chest and because of the electrical activity that we're picking up, we can tell whether it is inferior, which means it's the right coronary artery. So inferior here and primarily affecting the right ventricle. Anterior, which is the left anterior descending artery, the widowmaker, and then the lateral, which is it can be the left anterior descending, but it's more commonly the left circumflex because it's the most lateral part. Okay, so I hope I didn't confuse you too much. I tried to keep it as simple as possible without, frying your guys' brains. But if you have questions at all, go ahead and throw them in the chat. I wanted to introduce you to that. So we're not just saying, if we see these leads, raised up, this is what it is. We kind of get to the kind of meaning of what that actually means. Okay. All right, let's keep it moving. Go on to our next case. Let's have one other person read the case, please.
I will.
Awesome, thank you.
Okay, can you hear me okay? Oh, hang on.
I can, yes.
All right. A 33-year-old female with a past medical history of non-Hodgkin's lymphoma presents to the emergency department for shortness of breath and leg pain, following an extended cross-country road trip. She describes chest pain, of which is worsened by deep breathing. She also notes 2 episodes of coughing up blood. The patient is a current smoker. Physical examination reveals the following: tachycardia rate 117, Rales bilateral lower lung fields.
Awesome, thank you. I assume that's your baby that's crying in the background. I love it. It's cute.
That is my baby.
Oh, bless you for dealing, or not dealing, but having a child and still coming to virtual rounds. That's awesome. All right, so we have a few things that are going on here, and instead of me pointing them out, I want you guys to type in the chat or unmute yourself and tell me what's important about this case that we should have our sort of suspicion high about. Leg pain, yep, I agree, Emily. Excellent. Anybody else? Coughing up blood, yes. Does anybody know the acute medical word for that? Long road trip, yep. Immobilization is always important. The other way we might see immobilization is if it's an elderly person that doesn't walk or they just recently had surgery. It's worsened by deep breathing. Good, you guys are doing great. There's one other thing that I want you to kind of hone in on. And the acute medical word for coughing up blood is hemoptysis. Non-Hodgkin's lymphoma. Yep, it definitely is should raise our suspicion there because that's a malignancy, and malignancies come with all kinds of different things. Okay, so good. So we also see this patient has tachycardia, so the rate is pretty high. Not so high that we're like, okay, this might be AFib or a flutter, but it is fast, which can tell us a few things. Also has Rales in their lung field, so some noisiness there. But what test do we want to order? So what are you guys thinking is going on? Because those questions kind of go hand in hand. We can't just order tests and figure out what's going on. We have to have a differential. Good. So somebody says pulmonary embolism. Excellent. Anybody else? What are we keeping on our differential here? And it can be broad. I'm totally fine with a broad differential. Lung cancer. We can definitely keep lung cancer. We can keep pneumonia. Anybody else? What do you guys think? Have we ruled out cardiac causes of chest pain in this patient? No, yeah, you'll see. I'm sure you guys. How many of you guys are medical scribes in the ED? I bet you guys, a lot of you guys are, or a few of you guys are at least, or EMTs or anything like that. Unstable angina, yep. So destiny scribes, awesome. So you guys who are scribes or EMT or even if you're an MA, yeah, ICU care tech, exactly. So if anybody says they have chest pain in one capacity or another, a lot of people's sort of instinct is going to be to get an EKG. And often when they're triaged in the ED, the EKG kind of comes back to the doctor, and they'll look it over and sort of triage them that way. Okay, so that's often our first instinct. So yeah, we can't necessarily rule out cardiac causes. Does this patient have a lot of risk factors for cardiac disease? No, not really, but we can't assume anything. Anything's possible. Okay, so other than the EKG, what do you guys want to get? Chest X-ray. Yep, I agree. Good. Anything else? CBC, what are we looking at for CBC? Troponin, yeah, we can get troponins. Good. Yeah, we can look at WBC, make sure this patient has doesn't have an infection or anything like that. Okay, but one thing that we can kind of do to rule in or rule out, well, it's primarily to make a diagnostic decision about pulmonary embolism, is one thing. So let me stop sharing here for a second because I'm going to share a new screen for you guys to see. Let me share it here. How old I am by how quickly I can get to the next screen. All right. Here it is. Are you guys able to see this still? Perfect. So we're going to do this together. This is Wells criteria. It kind of us. It basically objectifies our risk for pulmonary embolism. Okay, so this patient, does this patient have clinical signs and symptoms of DVT? Yes or no? Yes, I agree. Okay, is pulmonary embolism the number one diagnosis or equally likely? Yes or no? Yes. Okay, good. Is the patient's heart rate greater than 100? Yep. It was 117. Has the patient been immobilized at least 3 days or surgery in the previous 4 weeks? Yes to that. Good. Previously objectively diagnosed PE or DVT? No, the patient hasn't had any sort of PE or DVT in the past. Does the patient have hemoptysis? Yes. Great. Has the patient had malignancy with treatment in the last 6 months or palliative care? Yes. Okay, so this patient has a pretty high risk. And the good thing about MD Calc, it's kind of a cute little calculator online that a lot of people use clinically, is this patient has a pretty high risk, 11 points, almost a yes for everything. So, this would be when we definitely pull the trigger on a CT of the chest, and it'll even tell you, next steps. We use the PERC rule to kind of rule out rule out PE, but in this instance, I think we can definitely pull the trigger. What's a test that you guys may know that is not necessarily specific, but sensitive? Do you guys remember what that test is? Would contrast be used during the CT? So yes, usually yes, but usually it's a CT angiogram. So yes, so we're looking at the pulmonary artery specifically. Good question. D-dimer, yes, excellent, Seema. That is the test that we're going to use. Usually it's to kind of rule out. Some people call it like D-dimer roulette because if it's positive, that means you definitely have to work it up or kind of figure out why it's positive, because a D-dimer tells us that there is fibrin split product somewhere in the circulation, but doesn't tell us where. Okay. In this instance, we kind of know that this may be, an issue with the lungs, but it doesn't necessarily kind of tell us otherwise. But we'll keep going. So here's the D-dimer. It's positive. And we've probably already pulled the trigger on a CT angiogram, probably a chest x-ray too, but here you go. Here's some more information. Here's the patient's leg. What's wrong with this leg? And what does this point us in the direction of? Yeah, there's edema, there's erythema. So what we're looking for is unilateral leg swelling. It's erythematous, and obviously we see that edema. Sometimes it's pitting edema, meaning when we push in, it kind of leaves a little pit, which is bad. But that could kind of point us in the direction of a DVT. Exactly. And when we see a DVT, we know that that is absolutely a risk factor for a pulmonary embolism. Okay. And here's your CT scan. And luckily this has arrows on it, which I always love arrows, especially when the radiologist put them in. But we see, the scan has contrast, as Destiny very wisely pointed out that we would use. But we see here is the pulmonary artery right here. And then what we're seeing, here's the aorta, and then we're seeing in this pulmonary artery as it branches this clot right here, which is bad. Okay, so this patient definitely has a pulmonary embolism here. We see maybe bilateral ones. Here's another one over here. Okay, so this patient has bilateral pulmonary emboli, which is no good. Okay, so here's the well score. We already calculated that. It's a quick thing to kind of punch in to say, what's this person's risk of a pulmonary embolism? If the shoe fits, nobody's going to fault you for ordering the test. If you're unsure, we might use the PERC score to rule it out, or Wells criteria to decide. And there's a Wells criteria for pulmonary embolism and Wells criteria for DVT as well. But here we are, we're talking about the pathology of the pulmonary embolism, which is a clot in the pulmonary artery. What do we see on exam? We see fast breathing tachypnea, we see tachycardia, unilateral leg swelling corresponding to that DVT. And then we see hypoxia, we can see jugular venous distension, at the angle of the neck. And then we can see hypotension as well. How do we treat it? We use anticoagulation. So we use novel oral anticoagulant medications. So that's usually thrombin inhibitors or factor 10A inhibitors. So that's drugs like agatroban, dabigatran, that's the thrombin inhibitors. And then the factor 10A inhibitors are acutely have XA in them. For 10A, which is nice. It can help you remember the mechanism of action. But here's a diagram here that I'm drawing next to. When we're inhibiting thrombin directly, remember that thrombin is the cofactor for from fibrinogen to go to fibrin to form the fibrin clot. So that's our goal in clotting, is forming this fibrin clot. So if we inhibit thrombin directly, then we don't have that cofactor to form fibrin. Okay. Similarly, 10A inhibitors, they're inhibiting this factor here. 10A is a factor, cofactor for prothrombin to go to thrombin. So those are anticoagulants that as the name kind of suggests, prevent coagulation. All right. So here's kind of an algorithm over here to kind of help with your diagnosis of it. If somebody has a risk of has a risk of having contrast, or can't have a CT scan with contrast, we might use a ventilation to perfusion scan. So that's called a VQ scan. So sometimes we use that. So we look at the ventilation, then we look at the perfusion. Sometimes we use that in pregnancy, but the gold standard is the CTA. Okay. But that's just a little algorithm to kind of to diagnose the pulmonary embolism. But in the sake of time, I'm going to keep going here so we can get to our last slide, which I think is, oh, I added another slide, so I forgot about this one. So here's another thing, and just because I saw it today, and it's not that common, but on the EKG, we can see a finding of which is S1. So remember the QRS complex goes P, Q, R, and then here's the S wave. And then there's the T wave. So we see that S wave in lead 1. So that's what S1 is. Q3. So we see a Q wave. So kind of that deepening in the Q wave in lead 3. And then we see an inverted T wave in lead 3 as well. And what are the complications of this? We can see things like core pulmonary, which is right heart failure. We can see pulmonary artery hypertension. We see arrhythmias, cardiac arrest. We can see respiratory distress, things like that, pleural effusion. And we can see right heart strain because, as you can imagine, if we have a clot in the pulmonary artery, in this cartoon over here on the right, we can kind of see that, if it's in the pulmonary artery here, it's kind of causing decreased cardiac output and strain on the right ventricle here. And we know that the right ventricle is not equipped to deal with high pressures like that. And so right heart strain can certainly cause a problem for the heart and can cause kind of florid CHF as well. All right. Now, our last slide. All right, so I'm going to point to a couple of things here, and as a kind of summary, basically there's lots of causes of chest pain. Okay, so we can't kind of focus on just cardiac or just pulmonary or just infectious. We have to kind of take the symptoms into consideration. Okay, so say this is a patient here on the left hand side. This patient came in, has high blood pressure, has sharp chest pain that radiates through the back, okay? And then we look at the CT and we see this. Bad. What is that, guys? Yeah, good job, Madeline. That is a dissection, and that's bad. So what we see is we get a false lumen because of increased intraluminal pressure. We get a false lumen forming, and that's bad because that can rupture. That can cause a problem. Excellent. And then this one here, say this person comes in with shortness of breath after a motor vehicle accident. So on this left hand side we see normal lung, and then this side we see not normal lung. We see it basically just right here. What happened? What is that?
Pneumothorax.
Yeah, excellent. Good job. So that is a pneumothorax, and that's bad. What we want to do with that patient is we want to do emergent needle decompression at the second intercostal space between the ribs, at the mid-clavicular line. We want to put a needle in to decompress the lung so it can expand back out and get that air out of there. That's sort of a temporizing measure until we can put in a chest tube. We put a chest tube at the fourth or fifth, between the fourth and fifth intercostal space at the mid-axillary line. So that's kind of going to drain the residual fluid or air that's kind of coming out of there. All right. Excellent. Okay, so say we have this one where we're kind of going in a clockwise. I guess that is clockwise, right? Yeah, clockwise. We're going right here. And say this person is a smoker. They had a screening with an ultrasound. They have a palpable abdominal mass, high blood pressure, and is a smoker. What is that? So here's the normal lumen right here. And then we see kind of a another, what looks like another outpouching right there. What is that? So we're looking at the chest. This is a AAA. Close. So this is a AAA. So we'd be looking kind of like you know, right basically here, because the most common place for AAAs is kind of at the aortic bifurcation. So the aorta kind of comes down here, then bifurcates here. So we would likely see that that aneurysm like right here. So that outpouching, it's bad because when it gets too big, that can rupture, and that doesn't have that has a fairly high mortality rate. All right, so excellent. All right, so in the bottom right-hand corner, we get this EKG. The patient is, let's say, 33 years old, a female, recently had an upper respiratory infection, and is having chest pain now. It's better when they kind of lean forward, and we see, it looks like ST segment elevations in diffusely in a lot of leads. So not really specific for any coronary artery. The patient has a fever, chills. What are you guys thinking in terms of that? So they could be septic, yeah. So Madeline and Josh kind of got it together. So it's pericarditis for sure. Obviously, we would get a definitive test for that to diagnose it. But diffuse ST segment elevation on the EKG in the context of recent upper respiratory infection and positional chest pain kind of points us in the direction of pericarditis. And then this one, say the patient has a history of GERD, has been taking ibuprofen and NSAIDs for rheumatoid arthritis, and then all of a sudden got pretty bad abdominal and chest pain. And then now we see this, we see air under the diaphragm, bad. That's perforated peptic ulcer, perfect. Zane is absolutely right, good job. We call that free air under the diaphragm. And whenever I hear that, I always think of this professor that's like an emergency medicine professor at my school. He's always like, I don't know why they call it free air, because it's actually very expensive to fix that. So I always remember that when I see free air into the diaphragm. And then this one, you guys might be able to get this without any context. What does that look like to you? Oop. Pneumonia. Yeah, exactly. So that person may come on with cough, fever, chills, chest pain. Good. You guys did great with that. And those are other causes of chest pain that I didn't want to leave out. So great. So before we kind of end, before I take up any more of your time here with my inconvenience of my internet, which I apologize again for, let me launch the poll one more time so I can get an idea of where you guys kind of stand now in terms of the chest pain, approach to chest pain. How would you know if chest pain is related to anxiety? So it's basically, that's a great question. And I probably should have included that in here too, but that's a diagnosis of exclusion, mostly. So what we do when people come into the ED for chest pain, we don't say, oh, this sounds like anxiety, I'm not going to do any other tests. We're going to rule out everything. So we'll get an EKG. If they don't have any risk factors, if they're young and, they're hyperventilating and they have anxiety, and their chest pain goes away with treatment of their anxiety, then we would say, maybe that is related to anxiety. But, if somebody's a vasculopath and has hypertension, hyperlipidemia, and also has anxiety, we're not going to want to assume that that is because of anxiety. We want to rule out all the other things before we assume it's just related to anxiety or costochondritis or anything like that. That's a great question. All right, excellent. So let me end that. I'm going to share the results with you guys. It looks like a lot of you guys said some now, which is very humbling. I appreciate. I always enjoy teaching these sessions. And I think I'm back again in a couple of weeks or next week. I forgot, kind of lived day to day recently, but let me stop sharing that. Thank you all for coming. I appreciate it. And I hope you enjoyed it as much as I did. I'm sorry again for my internet troubles. It wouldn't be, 2022 if we didn't have some sort of technological problem. But that's it for me. If you guys have any questions at all, I'll stick around for a few minutes to answer anything. If you have any questions about, the session, about chest pain, about medical school, about anything, I'll stick around for a few minutes. Otherwise, I'll see you guys next time. I think I'm teaching again fairly soon, so I'll see you or someone else will see you. But thanks for coming. I appreciate you guys.